February 1st of this year for the State Innovation Models Grant and felt a focus on AIM would be the perfect subject to kick off the year. I'm Laura Kate Zeichkin. I am the Deputy for Healthier Washington, and I will be hosting today's webinar. Before we dive in, just a few housekeeping items. You may submit questions at any time. If we see a high number of questions on a particular topic, we'll pause to let our panelists respond. We are going to make sure that we have time for questions at the end of this webinar. So please make sure to use the online question pane to submit questions during the webinar. The slides are available for download in the handout section and will be available on the Healthier Washington website following the webinar. So we're going to do a quick sound check. If you cannot hear us now, check to see if your speakers or your headphones are turned off or plugged in. Check to see that your PC is muted or the sound settings are correct. You can go to your GoToWebinar sound settings to make sure those are correct as well. We have an excellent panel today. We are going to kick it off with the Healthier Washington Executive Governance Co-Chair, Dorothy Teeter, who serves as the Director of the Healthcare Authority. We also have Dan Lessler, the Healthcare Authority's Chief Medical Officer, on the line, and he'll be on throughout to answer questions. Adam Osaby is the Healthcare Authority's Chief Information Officer and has been serving as the Interim Director of the Analytics, Interoperability, and Measurement Initiative. Kathy Lofi is the State Health Officer for Washington State, and she joins us from the Department of Health. David Mancuso is the Director of Research and Data Analysis Division within DSHS. So we're going to kick off today's webinar. Thank you so much, everyone, for joining us. And at this point, I'm going to turn it over to HCA Director Dorothy Teeter.
Thanks very much, Laura, and good morning to everyone that's on this webinar. As Laura pointed out, we are working hard to ensure that our cross-agency collaboration for Healthier Washington is effective at the state level, and that we are excited today that our panel of experts who are going to be presenting and engaging with questions represent the three key agencies that are working together for the analytics, operability, and measurement area of focus. Next slide, please. Many of you have seen this slide before. It's our triple aim slide. It's our mission slide. Healthier Washington's focus is on really collectively transforming health systems in Washington State so that people experience better health during their lives, receive better care when they need it, and that their care that they do receive is both affordable and as accessible as possible. This is known in the industry as the triple aim, and we believe in Washington State that it is possible to achieve all of these aims simultaneously. Next slide, please. The Healthier Washington goals approach that we have built here in the state emphasize effective collaboration with communities as they connect their community assets with our traditional healthcare system. The Healthier Washington approach maintains a strategic focus on whole person care to improve health outcomes. So by that we mean ensuring that behavioral health needs and physical health needs are integrated so that the person themselves can access integrated services. And it also tests new ways of using purchasing dollars in order to both improve care delivery and lower costs as we make care more accessible. Measuring our progress and continuously monitoring our results is key to continuing to progress with what is effective. Next slide, please. Many people have asked at the end of the day when this innovation grant is over, what will be left in Washington State. I like to think of it instead as not a grant that will be over and then we'll be left with products per se, but really what is the state of the transformed health system once we achieve our Healthier Washington goals, which while we're starting right now is a journey that will take us many years into the future. I mentioned the integration of physical and behavioral health. That is incredibly important. As we all know, Probably there's no one in our families that hasn't recognized the need for seamless care. Accountable community health, linking again our communities with our health systems so that together we can collaborate to ensure we're using the best of all of the assets that we have in our state to improve the health of our communities. Clinical practice transformation, as you've heard from other webinars and probably in discussions, in order to really help move our healthcare system forward with new ideas of linking with community, with new ideas of accepting payment in a different way, we're going to have to make sure that we've got powerful support for our clinical practices along the way. So we will be investing quite significantly there. Value-based purchasing strategies, again, it's the relationship of cost and quality to ensure best value, and our testing payment models around what's the best way to do that. Equally important and a very burgeoning, I guess, strategy across the country is we're learning a lot better methods for engaging our patients with their healthcare decisions. So we've got work going on there that I would anticipate will be a very powerful force in the future as we go forward with achieving the triple aim. And then last but not least, the topic that we're here to discuss today, we will be using our analytics, interoperability, and measurement infrastructure and investments to ensure that what we're doing that works, we can measure. What isn't working, we can also measure, and we can continually improve through the investment we have in data and analytics and measurement of performance, how it is that we're doing and how we can continue to go forward, and honestly how we can share what we're doing with others both in the state and across the country. So today we are going to take a deeper dive into the opportunities that present themselves with analytics, interoperability, and measurement strategy. We fondly refer to this as AIM. And our first panelist is Kathy Lothe, who is, as Laura mentioned, the State Health Officer for the Department of Health in Washington State. Kathy, I'll turn it over to you.
Great, thanks, Dorothy, and good morning, everyone. So I'm going to start by first giving you just a high-level overview of AIM. So as you already know, AIM stands for Analytics, Interoperability, and Measurement. Analytics refers to using analytic tools to turn data into information that can be used for a variety of different purposes, and I will discuss some of those purposes shortly. Interoperability is the ability of different health information systems to talk or communicate with each other and exchange data. And it's particularly important for electronic health records to be interoperable so that patients in different healthcare systems can exchange information about a shared patient. Lastly, measurement is about using standardized measurement strategies. And as you guys know, measurement can be a really powerful tool for driving change and is a key component of the quality improvement process. AIM is a body of work that stretches across multiple agencies, but is particularly relevant to the Healthcare Authority, DOH, and DSHS. And we're trying really hard to break down silos across our agencies so that we can really maximize the use of the data in our state. And it's lastly important for everyone to understand that AIM is a component of Healthier Washington that really supports all the aspects of Healthier Washington, and it's a key lever for achieving better health, better care, and lower costs. So why are data so important to health and the Healthier Washington initiative? Well, first we need data to drive quality and consistency of care. Later I'm going to talk more about our common measure set, which is a statewide measure set we're using to improve the quality and consistency of health care delivered in Washington. Secondly, we need data to prioritize population health issues and guide implementation of population health strategies. Public health agencies have historically used data to assess the health of communities and target interventions. And the AIM work is very exciting to me because public health and accountable communities of health will now have new sources of data, such as clinical data, to support some of the population health work that will be done. And third, we need data to evaluate whether our strategies are improving health, healthcare, and costs, and whether we as a state are achieving the triple aim. Next slide. So this next slide highlights the common users of healthcare data. At the top, we have patients who are the consumers of healthcare services. Patients need access to their own clinical data so they can be actively involved in their healthcare decisions, something Dorothy mentioned earlier. We also want consumers to have access to data on healthcare quality so that they can use these data when choosing a provider. Next, we have clinicians and care teams. Healthcare providers and care teams need to be able to access their patients' medical records across care settings so that they can see the complete picture of the patient's situation. And this will ensure the provider is making the best clinical decisions for the patient. They also need to access their patient's information across care settings so they can avoid repeating diagnostic tests unnecessarily. Next, communities need patient-level data across all the healthcare delivery systems in the community so they can assess the health of the community and target population health interventions. And lastly, healthcare purchasers need timely data on health outcomes and healthcare quality to drive value-based payment and performance. So the figure on this slide was developed by the Office of the National Coordinator for Health Information Technology, and while it is somewhat complex, it does nicely depict a future vision for what the Office of the National Coordinator calls a healthcare delivery ecosystem. ONC really envisions a future where health IT systems are interoperable and data are used by multiple stakeholders for continuous quality improvement processes. And to demonstrate this, on the left side of the figure, you can see how patient-level data can be used to calculate quality measures for a practice, which can then be used for clinical decision support. The middle section of the slide shows how practice and population-level data can be used to perform public health assessments, which therefore inform public health policy. And lastly, on the right side of the slide, it shows how population-level data can be used for clinical research, which will then inform clinical guidelines. Next slide. So if you're a member of the public, you may be asking yourself, okay, this all sounds great, but really what's in it for me? Well, when we successfully achieve the goals of AIM, we will hopefully have improved coordination of care. So for example, when you go to your doctor's office, your provider will have information about your visit to the emergency department last week. And you'll also have more information about the quality and cost of care you are receiving, which will allow you to be a better consumer of health care. And lastly, as the state health officer, I'm most excited about using data to hotspot diseases so we can target prevention activities and achieve better health across our communities. For those of you who aren't familiar with the term hotspotting, it basically means using data to show which parts of a region or a community are most affected by a disease. So next, David Mancuso, who's the director of the Research and Data Analysis Division for DSHS, is going to review some key objectives for AIM.
Thank you, Kathy, and good morning, everyone. AIM's objectives, if you wanted to sort of put it at a high level, will be accomplished by making smart investments in technology, in people, and in the subject matter expertise that's really necessary to support the expansion of information sharing and health analytic capacity in the environment that we all work in. Examples of some of the investments and activities currently underway include the work of the Providence Corps developing dashboards for accountable communities of health, the development of the statewide clinical data repository in partnership with One Healthport. In terms of getting into greater detail in terms of how this is going to roll out, a great deal of work was done last year, next slide please, last year with Gartner to develop a roadmap for development of a platform and other analytical investments in the AIM environment. And work is progressing to define and acquire the specific investments to build the AIM's analytic platform. A little bit later in this presentation, Adam Ossaby will provide a little bit deeper dive, including some timeline information about these investments. Next slide, please. As this work progresses, we would expect that state agency data owners, or stewards, if you will be engaged to discuss how their data might contribute to this analytical environment. Of course, DSHS and Healthcare Authority share a common claims and encounter platform in Provider One, and that's a big part of what we think of as being in the in the wheelhouse of this development of analytical infrastructure. But there's an expectation that we're going to be reaching out to other state agencies and looking at, for example, federal Medicare data as an aspect of this larger integrated data environment. We'd expect data sharing in this environment to be done, in accordance with relevant state and federal laws and regulation. Data sharing generally governed by contracts among data owners that will align the use of the data to the requirements of the legal environment that we share. Towards that end, a lot of work is being done to develop a consensus understanding of privacy rules, and our agencies, collectively our agencies' attention to security and privacy requirements will continue to be paramount as we build out this capacity and infrastructure. Next, Healthcare Authority Chief Information Officer and Interim AIM Director Adam Osaby will put it all together for us.
Or at least I'll try. Thanks, David, and good morning, everybody. My name is Adam Osaby, and as folks have heard, I'm the CIO here at the Healthcare Authority. We're going to go ahead and start diving down a little bit deeper into some of the work that we have going on here within over the course of about the last year now, and I think we can hit the next slide. So this one will take a second to kind of walk through, but I'll start at the bottom. As David mentioned a moment ago, there is, and Kathy alluded to it as well, we have an amazing amount of data within the state of Washington. The DSHS, DOH, and the Healthcare Authority are responsible for. When you think about AIM, the way that we look at it is as a collection of strategies intended to catalyze improvements in how we best leverage all of these massive data sets that we have in the most responsible way, and again, hitting on what David just said, ensuring the privacy and security of all that data as well. When you look at the bottom section there, you have the 3 state agencies listed out, and then you see in particular between the Healthcare Authority and the Department of Health, arrows pointing towards a dashboard reporting tool. I'll go into detail on that a little bit later on in the presentation, but that's with an organization that we work with named Providence Core. But there's also dashboarding that is going to be soon available with a number of different partners, and I'll walk through that in the next couple of slides. When you go up to the next level there and you see analytics, interoperability, and measurement, I strongly encourage folks to think of that in 2 different ways. One, to a certain extent, it's a place, it's a data warehouse, but it's also how all of these different strategies are able to go in and achieve the goals of AIM. I don't think it's not the intention of us to say that every single data set that you've got out here from all of these different organizations eventually winds up in this data reporting structure, but there is certainly an end goal there when it comes to the state data sets that we have collected. When you go up to the next level, we have a number of key partners, either that we run out of here with the Healthcare Authority or that we work on with other organizations. Starting on the left with the Washington Health Alliance, which is a key partner for the state. They produced the Community Checkup Report, which was released on December 8th, and I very much encourage folks to go to their website and take a look at what they are reporting out on. It's a report that just measures the 52 common measures that we have throughout Washington State, and is an incredible source of data, and that organization has done a fantastic job assembling that. Our partners over at the Office of Financial Management right now are working through the details on procuring a vendor to build out an all-payer claims database, and I'm sure more is to come out on that in the near future. And then the Healthcare Authority is operating the beginnings of a build-out of a clinical data repository that we refer to as Link for Health. There's also a slide a little bit later on in this presentation that I'll dive down into detail on a little bit further that talks about what the CDR is. Next slide. This is a timeline. So about a year ago, as we started looking through what we needed to do with AIM, we were looking at doing a couple of different procurements right off the bat, and what we decided we needed to do was to wait, do some diligent planning efforts, and really think through exactly what it is that we need and why. We worked with an organization called Gartner Consulting for the course of about 6 months. They interviewed about 250 folks around the state in a number of different organizations, and they returned a roadmap for us that helps us think through exactly what we need to do in order to make sure that the goals of AIM can actually be successful. That is represented in the top bar there with AIM program initiation and planning. At the same time that that's been happening, we've been doing quite a bit of development work with our multi-agency group around program implementation and governance. We are in the beginning process right now of thinking through Healthier Washington data information governance as well. Within a week or two, I'll give ourselves a little wiggle room just in case we hit a bump, but within a week or two, we will be issuing a series of requests for information, RFIs, and there'll be a fair amount of information in there around requirements that we know that we have in order for this work to be successful, but then also some information so that vendors can take a look at what it is that we're looking to build out, and they can then start to work with us and inform us before we go out with the full RFP later on in the spring as we look to build this work out. That then gets us into the AIM business intelligence analytics implementation, the AIM logical data warehouse population as far as the data being populated within there. While all this is happening all at the same time, we still have Healthier Washington support that we're responsible for, and I'll go into more detail on that in the next two slides, as well as AIM program monitoring and reporting. So as we can see, obviously a lot of things happening all around the same time. Next slide. So with this one, what I'm going to do is just walk through very briefly a number of different places here, because one of the things that I hear a lot when we go around the state and do some of our presentations and talk to our key stakeholders is people want to know how all this stuff fits together. And I'll be very upfront about it, like I am in all the other opportunities. It's not going to be perfect as we're building it out. There's an awful lot of flying while we're building going on with this effort, and I think there's a certain level of ambiguity that we need to be comfortable with as we're building this work out. But at the same time, there are a number of concurrent data initiatives going on all at the same time in support of Healthier Washington. The first we just mentioned was AIM, so I'll skip through that. I already mentioned the Washington Health Alliance and the official reporting tool for the Washington State Common Measure Set. The Healthier Washington Dashboard Reporting Tool. Again, I don't want to get too far in front of a slide. I have a little bit later on, but this is a visualization tool for specific key measures critical to ACH organizations, and is AIM's initial attempt to be able to provide data out to our accountable community of health partners so that they can be better equipped to do the work that they need to do. Mentioned the All-Payer Claims Database and the work happening there with OFM. Also mentioned the clinical data repository and the ability to store claims, encounter, and summary care documents of a longitudinal record for patients around the state within Apple Health and Public Employee Benefits. Next slide. We have 4 different payment redesign models, as folks may have heard during the course of previous webinars. One of those payment redesign models is around a multi-payer solution to enable value-based payment. That's something that is being developed here within our Healthier Washington team, and there should be more information coming out on that soon. The Department of Health has an amazing tool called the Washington Tracking Network, as well as CHAT. And these are community health assessment tools that we are looking at different types of strategies on how to make those available in a more broad way. But it's a fantastic collection of tools that Kathy Lofi and her teams have put together here over the last couple of years. We have an official evaluator for the Healthier Washington initiative, which is the University of Washington, led by Doug Conrad. This is an academic and formal evaluation of Healthier Washington strategies, and over the course of the next couple of months, we're going to be working out how to share a broad base of information and data with the University of Washington evaluators so that they can report back to our federal government accountability organization, CMMI, the Centers for Medicaid and Medicare Innovation, about how well we're doing with this work. And then lastly, a number of folks are likely familiar with the work that David Mancuso has done over at DSHS in building out the Predictive Risk Intelligence System. It's a predictive modeling tool that provides claim-based view of health services experiences of Medicaid enrollees, and is one of the best homegrown apps that I think that you'll see in any state organization anywhere around the country. Next slide. So this is my personal favorite because it ties everything together, I think, in a nice and simplistic way. So when you think about Healthier Washington data, and when we say that, of course, again, we're referring to DSHS, DOH, HCA, but then hopefully also getting into social determinants information in the very near future. At the very top up there, of course, you have to focus consistently every single day on data governance and security. It's a major goal for us here at the Healthcare Authority, but then also a goal for our partner agencies as well. Visual dashboards, and that's one because we we right now are stuck in a loop where you have to be a SQL or a SAS programmer in order to be able to interact with or build out data visualizations. And what we want is for folks like Dan Lessler, our Chief Medical Officer, to be able to go in and view dashboards in a way that that just makes it common sense. So you can be a complete data geek and understand how to look at the visual dashboards, or you can be the director of a state agency and also be able to access it. So it's just a way of making our data more available for folks to be able to interact with. Hotspotting is something that we are starting to think through. We have a number of different options here, both within the state government agencies as well as some potential vendor engagements that we're looking at around being able to do more hotspotting around the data sets that we have. Clinical decision making, and again, being able to help the different medical professionals that we have working in our state agencies to be able to make better decisions off of it to inform the clinical work that they need to do. Common measure reporting, I've already mentioned with the Washington Health Alliance. And then, as folks I'm sure have heard consistently over time, the massive impact that the social determinants of health have in terms of making sure that we are looking far beyond just the health data as a way of being able to add value and increase the quality of care that our clients are getting from us around the state. Next slide. Sorry. Okay, sorry everybody, I had to take a quick pause. We were doing a quick administrative thing here in the room real fast to make sure that things are going okay. I think Laura's back on now.
Adam, we have several questions that have come in that before we transition to talking about the common measure set, I'm wondering if we could take a pause and start to answer some of those.
Would love to drink some water. It's great.
Wonderful. So thanks for running through the concurrent data initiatives and what many of our partners are doing with the state in order to make AIM come together. Can you tell us more, Adam, about CORE and their role, as well as where they come from and their sort of demonstrated expertise?
So we have a slide a little bit further into this presentation, and I'm wondering if we could skip our way through to it real quick, because it would help me talk through it very quickly. It's right after the measures component of what we're doing. It's on slide 27, if we're able to do that. Oop, a little fast there. There we go. Perfect. So CORE is an organization down in Portland, Oregon. It's the Center for Outcome Research and Education, I believe is their official title. They're a group of data scientists that has been working with the Oregon Healthcare Authority now for about 3.5 years. And what they do is they provide assistance by taking unstructured claims and encounter data sets, structuring them, and then returning them back to, in Oregon, their version of ACHs in a interactive dashboard that allows for those folks then to be able to take that data and immediately make actionable decisions off of it. What we recognized here about 6-7 months ago, and we've known it all along, we're at the Healthcare Authority right now at the art of dissemination. We have a lot of work to do here to advance how we turn our data into something that we can then share with our partner organizations. And what we decided that we needed to do was work with an organization that had a proven experience working with claims and encounter data with a similar Medicaid agency down in Oregon. And they are an interim AIM solution to be able to provide HCA and the ACHs with actionable data and analytics. The initial plan is to provide data on the statewide core measure set derived from Medicaid, public employee benefits, and DOH survey data. There's a future plan to include additional data on population health and social determinants, but that's further down the road. It does support ACH desires for population health data and social determinants of health data, and it provides ACHs and DOH, and this is obviously a key component as we keep hitting on the security and privacy piece. As non-HIPAA covered entities, we need to make sure that the data that we get back is in an aggregated, de-identified way that's visualized via Tableau software in an interactive dashboard, but in a way that doesn't allow people to have access to the underlying information. So it's a group that we're really excited on working with. We view them as obviously a very key partner in all of this work, and we also ensure that we have a good partnership built up between Providence Core and the Washington Health Alliance, because we're trying to make sure that we don't cause too much confusion in the work that we're doing with these different organizations. Hopefully that helps a little bit.
Thanks so much, Adam. David, we have some questions about the integrated client database, which lives within DSHS. How will this be included in AIM?
That's a good question. I would encourage folks to think about the integrated client database in RDA as a construct that exists through a network of agreements with underlying data owners both within the Department of Social and Health Services, its various administrations, and the external organizations, generally other state agencies, or in some cases federal agencies, with whom we have agreements to integrate data to do particular types of work. What we would anticipate is that there'll be interest in some of that, some of the sources that feed the integrated client database in DSHS to also feed the AIM analytical environment as well, and that those data owners who we have agreements with in RDA and who provide data that we integrate into our environment would be approached for entering into potential agreements that would allow that data to come into the AIM platform, and through those agreements that would govern the use of that other state agency data in the AIM environment. So what folks shouldn't anticipate is, generally we have agreements with data owners that define how we can use or redisclose. You have other regulations like HIPAA and 42 CFR Part 2, among other elements of state and federal law that govern to whom information can be shared and for what purposes. So what I would anticipate is a process where data owners would enter into contract to share information in this environment for uses that are governed by contract terms and by the larger state and federal legal, statutory, regulatory environment.
Perfect. So thank you, David. We're going to start moving along, and we have a handful more slides to get through. And I'm going to move it over to Kathy Lofi. She's going to talk a little bit about the common measure set. What is it, and how we're using it right now.
Great, thanks, Adam. So Adam has already sort of referred to this. We're going to back up a little bit and go into a little bit more detail about the common measure set. So back in 2014, there was legislation that was passed that mandated the Healthcare Authority to convene stakeholders and develop a statewide common measure set. One of the primary drivers behind this legislation was the need to standardize the way we measure performance as a state. The common measure set also promotes a voluntary alignment of measures across all payers and purchasers. And the results from the common measure set are publicly shared to help us all understand what needs to improve and where we need, what needs to improve and where it needs to improve. So, but ultimately, I think our hope is that this common measure set will eventually ensure equal access to high-quality health care by reducing variation in care across the state and really improving health outcomes. So could you go to the slide with the boxes on it? Oh, great, thank you. So a performance measure coordinating committee was convened back in 2014 after the legislation was passed. And this group completed the development of what we called an initial starter set of 52 measures in December of 2014. These 52 measures fall into three different categories, as shown by the different colors on the slide. A majority of the measures in the common measure set measure clinical processes and health outcomes, as is shown in blue in the middle of the slide. I like to just call these measures the clinical measures. Results from these measures are reported either on the health plan level, the medical group level, or hospital levels. And some examples of these clinical measures include one, for example, the percentage of women 50 to 74 years of age who've had a mammogram to screen for breast cancer. And another example is the percentage of people with diabetes who have received a hemoglobin A1C test during the measurement year. So as you can see, these are measures that are really measuring healthcare processes and outcomes. In addition to these clinical measures, there are also some population health measures to track the prevalence of diseases or risk factors in populations. And most of those measures are reported out on the state and county and ACH level. And then there are also a few cost measures that track costs, such as Medicaid spending per enrollee. One thing I really want to point out about the common measure set is that it is a set of measures that will continue to evolve, and it already has evolved. Since the initial measure set was completed at the end of 2014, there have already been some changes to the set. In 2015, the Performance Measure Coordinating Committee added a few new measures that are focused on behavioral health issues and made a few changes to the initial set of measures. And so this starter set will just continue to be reviewed and revised over time as possible, as it's needed. We've also received a number of questions about whether additional population health measures will be included in the common measure set. And currently, the plan for improving population health is under development and is scheduled to be completed in September of this year. And as part of the work going on to develop this plan, the group working on the plan are also going to, as part of that work, are going to develop a measurement framework for the population health objectives. And we intend to then sort of align and integrate that work from the plan for improving population health with the common measure set. So more to come on that front. Next slide. Okay, and so Adam also quickly mentioned the community checkup report. To give you a little bit more background, the Healthcare Authority has partnered with the Washington Health Alliance, as Adam explained, to both develop and maintain the common measure set. And in 2015, the Washington Health Alliance produced a report with the results of the initial 52 statewide measures. And this report is called the Community Checkup Report. It is posted online at www.wacommunitycheckup.org. And the nice thing about this report is that the information in this report is objective and it's comparable across the entire healthcare system. We feel that public reporting of the results of the measures is really essential for transparency. So we do plan to continue to publicly report results in the future. And it makes objective information broadly available to everyone in the healthcare system and really highlights both where Washington has cause for celebration and where there is cause for concern. And Adam has talked about the Providence Core tool, which is another tool for being able to disseminate the results from the common measure set. I don't know if you want to.
Sure. Okay. So thanks, Kathy. So we've had a couple of questions that have come in on the clinical data repository. This is Adam again. I'm going to walk this through the last couple of slides here, and then we'll get to other questions. But hopefully, this will answer a few questions from folks. So about 2 years ago, the Healthcare Authority made the decision to build out a clinical data repository, and we worked with our managed care organizations to come to an agreement about the financing of that, and then we set up a contract with One Healthport, which is the state's designated health information exchange organization, who then went out and procured a vendor to build out our clinical data repository. A couple of points on this. The goal here is to support broad healthcare reform with additional tools are needed to support the sharing of patient information among members of a patient's care team who work in different healthcare organizations. So if you're a provider, you're typically not able to track your patient as they move across different provider systems during the course of a day or a year or however long you want to look at it. The CDR offers a common place to bring in health information from different healthcare organization EHRs and to share it with authorized providers only. The repository brings the data together into a single patient record that provides all members of a care team with a more comprehensive understanding of the patient's medical history and needs. The CDR will only make identifiable information available to providers directly serving Apple Health patients and is permitted under HIPAA privacy law as data is used by authorized providers for treatment and payment and operations. It's important to note that although HCA is the first customer of the CDR service, it is available to other payers and organizations to set up as contracts through One HealthPort, and a couple of organizations are already starting to go down that path. And this is intended to go beyond just Medicaid and public employee benefits. And then lastly, from a reporting perspective, over time, HCA will be able to extract aggregated information, not personally identifiable, for population health management and to measure whether or not the health of the population we serve is improving over time. So it's a tool that we're pretty excited about. We're probably a year and a half or so away from being able to launch it. We have been testing clinical care summaries, moving back and forth between first mover organizations who are involved in this work, and also doing data testing on our side to move data back and forth. So pretty exciting initiative and something that we're pretty thrilled to get started on. Next slide. So coming soon as far as engagement opportunities. So the Healthier Washington team is planning to launch an advisory group of key stakeholders at some point during the spring. This will include just beyond the 3 different state agencies involved to a number of our community partners, ACH representation, few private organizations as well as other local governments who would have an interest in being involved in that. And we will we're going to start reaching out to folks for participation here in the very near future. With the goal here is that they will be able to provide feedback on the AIM strategy and execution so that we can make sure that we're getting the best possible result out of this work. Communication strategies are also being targeted for the public, our partners in the accountable communities of health and other key stakeholder groups, and we're looking at a number of communication opportunities and options to get this out in as broad a way as we possibly can. Next slide. So in summary, I mean, as folks can see here, we obviously have an ambitious data strategy initiative. You know, there's the lift here is pretty enormous, but at the same time, we think that the opportunity and groundswell that we have of support on this work will help to carry it through to success. There's a lot of groundbreaking levels of interoperability going on. Physical and behavioral health integration is moving quickly. We have our first early adopter region launching down in Southwest Washington right now. The behavioral health organizations launch on April 1st, and we're really excited to see what happens there. Looking at bringing together data from multiple agencies, I think just looking at the initial work that we're doing with Providence Core, and you look at integrating claims information for Medicaid and public employee benefits with Burfus Public Survey, pregnancy data, and immunization data from the Department of Health as a starting point, has a really interesting opportunity for us to start integrating our data to the benefit of all the different organizations involved. And then, you know, first and foremost in all this is supporting the communities as they work towards local data capabilities. So, you know, we're pretty excited about it. We're intimidated by it. But we're pushing forward, and we're pretty excited to see what we can do for a healthier Washington. So with that, I'll kick it back over to Laura, and we're happy to take any questions you guys have.
Thanks, Adam, and thanks to all of our panelists today. We do have Adam, Kathy, Dave Mancuso, and Dan Lessler on the phone to dialogue with you and answer your questions. Just a reminder to submit your questions through the question pane, and we will make sure to address them. The first question, I believe, is for all of our panelists. As many of you know, Healthier Washington is not just about the traditional health care sector, but really embraces this 80-20 proposition that 80% of health happens outside of the clinical delivery system. How is AIM going to embrace that, and how will AIM incorporate, report, and inform Healthier Washington and the state by integrating the social determinants and predictors of health?
This is Adam. I'm going to put Dan and Kathy on the spot. I would think as our MDs on the call, I would think they would be best positioned to talk about the social determinant integration work.
Yes, hi, this is Kathy Lope, and that's a very good question. You know, we I'm very excited as a public health official to hear more people talking about, the 80-20 rule, which people sometimes refer to because, as we've learned over time, only really 20% of our health is really determined by what happens in the healthcare system. So yes, we are very, very interested in incorporating social determinant of health data and integrating social determinant of health data with healthcare data. And we've already started to do that some at the Department of Health. What we do as AIM, I think, have a vision of integrating that data, which will really help, I think, people see really the bigger picture of health as opposed to just looking at the healthcare picture. So as Adam mentioned earlier, we are developing a tool at the Department of Health called the Washington Tracking Network. And within this tool, we have started putting in some of the social determinant of health data. So for example, the Washington Tracking Network is a mapping tool, and you can now go in and look at, it maps like the proportion of kids that are living in poverty. So you can view maps and view communities down to, smaller geographic areas and really, be able to better understand poverty in your community. And right now, what's really exciting is that the folks at the Department of Health who have been working on the Washington Tracking Network and the social determinant of health data have been working pretty closely with the folks from Providence Core, who are mainly working with the Medicaid clinical data, and they have come up with some potential solutions as to how those data sources can be integrated. So I actually think we may be not too far away from being able to, be able to view both the clinical data and social determinant of health data, within a single tool.
Thanks, Kathy. Dan, would you like to add anything?
I think the only thing I would add is that sort of coming at it the other way and being able to look at utilization in very narrow geographic areas. So, and I think Adam referred to this earlier, just in terms of the notion of hot spotting. So, for example, the ability to identify, very focused localities where, for example, you have a very high use of ER use or hospitalizations or something along those lines, as a means of, for example, helping to direct the efforts of healthcare systems to focus on specific geographic areas. So I think that would be another example.
Thanks, Dan. We do have a question about tribes and data that's coming from the tribal health systems. Where does tribal data come in when it comes to the measure set, the transparency of data, and also how is it going to be integrated into the AIM systems? Adam, do you want to kick us off with that?
Yeah, I can start it for a quick second. So it's a great question and one that's come up a couple of times. I've had the chance to go and speak to the tribal liaison group that Healthcare Authority and DSHS now jointly run, I think either once a month or once a quarter. And they certainly have a number of questions related to how we're going to be handling geographic boundaries. If it's just going to be ACH reporting, how do we get down into the subregions and draw the tribal boundaries around that? And those are all great questions, and they're questions that we don't have the answers to yet until we start working our way through it. We do, for Medicaid recipients, on the fee-for-service side, for the work that we do here, we do have data related to the fee-for-service tribal populations, and that's information that we wouldn't want to segment out of anything that we're dealing with as we work on the AIM work. But We've let the tribal liaison group know that the advisory group was going to get started, looking on having a couple of representatives, knowing that we can't just have one. So probably look to what we've talked with that group about before is having 2 representatives, potentially 3 around the state, and we're working with Jesse Dean, who's our tribal liaison coordinator here at HCA, around how that interaction is going to work. So through that group is where we'll end up getting the information coming through. So I think there will be advisory group opportunities there, and we're very much looking forward to our experts and representatives for the tribal regions being able to advise us on how to make this data valuable to them as well, and not just for the ACH areas. The other thing I'll mention too real quick, because we've had a few questions come in about the advisory group. Here at the Healthcare Authority, we have a program manager named Amanda Lisney, Lysne. Amanda will be the one coordinating the work around the advisory group, and if you have liked kind of what you've heard today and have an interest in being involved, you can reach out to her, and her phone number is 360-725-2081, and we'll also make sure that we have something out on our website that tells folks how to contact her as we start to roll out the official invitation. So I don't know, David, if you have anything that you would want to add about tribal data, anything that you've done at RDA, or any thoughts?
Nothing really significant to add. In general, the tribal-related information that's available to us is the information that's in state IT systems, so the MMIS system, the Medicaid Management Information System, that is Provider One. So we tend to see only the data that's essentially Medicaid paid or paid by other state programs, and that can create significant gaps in available information for tribal members in a number of areas. And it's not an area where, unfortunately at this point, that we've built separate connections of that information that would allow us to paint a more comprehensive, integrated perspective of the experience of folks beyond what we can see in our state data systems.
Thank you, and thanks, Adam, for speaking to how folks can engage further on the advisory group. We have had a lot of questions about how to get engaged in this work as the effort moves forward. Similarly, we had a question about how folks can respond to RFIs and any other opportunities, and how that's going to be transparent and what that process looks like.
Sure. So right now we're targeting March 18th. It may be a few days after that. It'll kind of depend on how the review process ends up going here at HCA, but sometime in March, we'll call it that, there will be RFIs released through the Healthcare Authority's contracting office. Those are things that are available for anybody to take a look at. It's not quite as stringent a process as an RFP evaluation process, but what we're going to be looking for is organizations or an organization who can take a look at the different requirements that we need as far as the data collection strategy that we need to put into place, and just kind of help to inform us, advise us about what opportunities are out there, and really looking for a dialogue. I think one of the things that I've said on a number of these different types of presentations is none of these 3 organizations, none of us pretend to have all the answers on this. We know that we have an awful lot of wonderful thought leaders out there in the vendor community who have done a lot of work in other states, and we're looking forward to learning from those different organizations to best inform what it is exactly that we need to ask for in an RFP later on in the spring. So that will be, RFI will be something that's out on our website. It will be open for at least a couple of weeks for sure, and then we'll be engaging with responders in a series of meetings and discussions to figure out the next steps for us to take forward. So folks will see it there, and we're looking forward to it.
Thank you. We're getting questions, and we've had a lot of questions just out as we've spoken to our partners who are interested in this initiative about what kind of early wins, and I'm putting that in quotes, that we can see from AIM. Adam, you spoke to how we're building the plane as we're flying it, and we can't expect perfection right off the bat. I'm interested in hearing your 1 or 2 sentence early win, Adam, David, Dan, and Kathy, that we can expect to see from AIM, and how our partners can really will be impacted by it. So Adam, let's start with you.
Sure, great, thanks. Sorry to jump in there a little early. One of them's already happened, and it's important to always remember the M within AIM with the measurement side. So alluding back again to the community checkup report that came out on December 8th, the folks up at the Washington Health Alliance have done a great job of putting that together. They right now are trying to figure out ways that they can build an interactive web portal that allows folks to interact with the data, and that's something that they're in active planning mode on. But I think that's a win that's already happened, and it's a win that's going to continue to happen during the course of our engagement. The second one is related to Providence Core, and the measure reporting that they're going to be starting for us. They have had our Medicaid claims and encounter data now for about 6 weeks, and we're in the process of working on the public employee side as well. Their first dashboards are due back to us around the 1st of May. We've already seen a couple of mock-ups based on the work that they've already started doing with our data sets, but I think what's going to happen there is we're going to get that data in, we're going to analyze it ourselves, validate it, make sure that everything looks right, and then hopefully not too long after we receive that initial deliverable in the first week of May, we'll start to share that with our accountable communities of health, with our other state organizations, and then we'll have to have some conversations about how we publish those outward for folks to look at. But those one win's happened, the other win I think happens in relatively short order, and we'll see how things continue to progress out. So pass it over to David.
One thing to complement those items, I think the work of the interagency work group to develop a consensus understanding of the privacy environment, I think that's been a very productive body of work in the last 4 to 6 months. It's been great to see.
Kathy, what are you excited about that's going to come out of AIM in the next 6 to 12 months?
I think I'd echo what Adam said. I mean, I think all the work around the common measure set has been fabulous. And, when Gartner came to help us, they kept talking about that and how that has really pushed us ahead of other states by having that common measure set completed. I'm also really excited about the CORE work and the discussions that are going on between CORE and the Washington Tracking Network at this time, as I mentioned earlier.
Thanks, Kathy. And Dan, you are going to get the last word today. What are you excited about that's coming out of AIM and how will it impact partners?
Yeah, well, I mean, I'm not sure I have much to add to what already has been mentioned, and would underscore the common measure set and the community checkup and the extent to which I think that really is catalyzed the clinical community toward improvement, which is really very, very exciting. And of course, that common measure set is sort of dynamic. There's a committee that meets to review that and update it over time, and so look forward to seeing where that work moves as well.
Cool. And then this is Adam again. I mean, the other thing I just want to mention here that I think has been a really great win, all 3 large state organizations are coming together and working in a really proactive way around the siloing piece. I want to add a word of encouragement, especially to folks from the ACHs and the local communities on here, to encourage you guys to keep doing the exact same thing. The state or the feds are not going to be able to solve all of the data issues, and there's a lot of interoperability opportunities that I think can really get catalyzed and start at the local level. And so I really strongly encourage those folks locally to be working on how you can integrate your own data from a local perspective, and then we're happy to do our part as well, of course, at the state level to provide the same types of opportunities. So I think that's just been a really great win already, that we all keep coming to the table every 2 weeks and keep talking about it over and over and over again. So it's really been a great conversation opportunity for us.
Thank you to all of our panelists, and thank you to those who joined the webinar today. This concludes our Healthier Washington quarterly webinar. Please stay tuned for information on for more information on analytics, interoperability, and measurement. You can do so by tracking through our website, signing up for the Healthier Washington Feedback Network, and contacting Amanda Lisney, who Adam mentioned and handed out all of her contact information. Also, please stay tuned for information about the next quarterly webinar that will happen later this spring.